One, we are live.
Thank you. A very good evening to all of you. I, on behalf of the Indian Society of Cornea and Creative Refractive Surgeons, welcome you all in this wonderful webinar wherein we have a real master blaster who has who has an experience of 45, 46 years in the field of controlling astigmatism, is here to tell you about handling astigmatic errors by refractive procedure. We have with us Dr. S.P.S. Grewal, who is the founder and managing director of Grewal Eye Institute, Chandigarh. And he got his initial training at Patiala and then did his post-graduation from PGI Chandigarh and then his fellowship at Moorfields Eye Hospital, London. And then became a consultant at PGI Chandigarh and resigned after at the position of associate professor and started his Grewal Eye Institute. He has done extensive training in the field of clinical and surgical procedures in glaucoma surgery, corneal transplants, iridectomies, vitreoretinal surgeries. He was initially trained in that. And he is a surgeon par excellence. He is very good, vastly knowledgeable in the field of cataract and refractive procedures. And he also started School of Optometrists with a 4-year degree course in ophthalmology in collaboration with IGNOU. He has presented various papers, instruction courses, and talks as a faculty at national and international platforms, and has various publications in national and international peer-reviewed journals. And some of these articles are really extremely good articles, which are cited very often. So we welcome Grewal sir in this webinar. We have with us two extremely good panelists who will be discussing again regarding this topic. Dr. Suresh Pandey, who is the director, Suvi Eye Institute, Kota, Rajasthan. He has done his post-graduation again from PGI Chandigarh, and then he went on to do his anterior segment fellowship at USA and Australia. Currently, he is the director of Suvi Eye Institute, Kota. He has, again, many publications to his credit, textbooks, chapters. He has done live surgeries in various conferences. He has received achievement awards by various organizations, especially special mention is American Academy of Ophthalmology. He has received the gold medal by IRSI, has received multiple times Best Video Awards by AO, ASCRS, ISCKRS, and is a truly academic person and a very good surgeon. Again, we have with us Dr. Piyush Kapoor, who is the chairman and managing director of the Healing Touch Super Specialty Eye Center at New Delhi. He is one of the leading ophthalmologists known for his excellent surgery, particularly in the field of phacoemulsification and refractive procedures. He's a high volume surgeon, approximately 5,000 to 6,000 surgeries in a year, does toric IOLs, multifocals, refractive procedures, and he is an apt panelist for this type of a topic. He has done his fellowship in pediatric ophthalmology, has worked as consultant in Department of Ophthalmology at Sir Gangaram Hospital in New Delhi from December 2005 to 2009. And he has been an invited faculty in various national and international conferences, a very good surgeon, a very good academician. We welcome Dr. Piyush Kapoor. And with us, we have our president, Professor J.S. Titial, who is the leading force behind all the academic activities of ISCKRS. He guides us, he encourages us. He is not only the president of ISCKRS, he is the chief of the center now. And he has numerous publications, loads of experience in the field of cataract and refractive surgery. He has received many awards, including the Achievement Awards at the American Academy, the P. Shiva Reddy Award at AIOC. He has numerous orations all over the country. And he was the first Indian to have performed live cataract surgery at ASCRS. And he also received the most coveted Padma Shri from Government of India by the President of India. So we welcome our President, Professor Titial sir. We also will be joined shortly by Dr. Rishi Mohan, who is the Vice President of ISCKRS, has received his training, specialty training from RP Center AIMS, and then went on to do his training at UK. He has also done fellowship at various places in United Kingdom and has received numerous awards. He has held various positions, which includes the previous secretary of ISCKRS as well. Has been joint secretary of DOS, member scientific committee AIOS, treasurer of EBI, and of course, again, a very academic person. We have with us Dr. Rajiv Mukherjee, who is the treasurer of ISCKRS and director and senior consultant Mukherjee Eye Clinic. He is a visiting professor at Greenberg School of Medicine, USA, an established cornea and phaco surgeon, has presented various papers and courses at international and national level. And we have Professor Namrata Sharma, who will be joining a little later. She's stuck in something else in another session. She is the chairperson, scientific committee, ISCKRS, and also professor of ophthalmology in the cornea and cataract and refractive surgery services at RP Center, AIMS. And she is the secretary of AIOS and Eye Bank Association of India and regional secretary, APAO. And she has numerous publications, chapters, and textbooks to her credit. And she is, again, a truly academic person. And myself, Dr. Rajesh Sinha, secretary, ISCKRS. So, before we actually start the talk by Grewal sir, would like to have some comments from the president ISCKRS, Professor Tityal sir.
Thank you, Rajesh. I think it's the Friday which we all wait for, to have a sessions which incites all of us to have a good discussion on a common topics. And today's topic is such which will be interesting to not only the people like us, to a general ophthalmologist also, because we all know astigmatism and its management is a key point for getting a good outcome in cataract surgery. In fact, any ocular surgery, one of the most difficult part to explain in the post-op period is astigmatism. And I'm very happy that Dr. Grewal sir has agreed to be a speaker in this particular topic. And who will be better than him to really chart out all the points on astigmatism and its management. And I'm pretty sure with the panel we'll have a terrific discussion, and everybody will be able to take some key points from this particular webinar of ours. I still like to have acceptance from the people who have joined us today to send some queries so that we can have good discussion after the presentation of Dr. Grewal sir. Thank you for making for this evening, Dr. Grewal sir, Suresh and Piyush. Let's have a beginning of this session, Dr. Rajesh.
Thank you, sir. So now we invite Grewal sir for his talk on handling astigmatic errors by refractive procedure.
Thank you so much, Dr. Rajesh and Professor Tityal, for giving me this opportunity for this evening to be with my fellow ophthalmologist. I'll try to keep my talk fairly simple and focus on to the practical points that we face in decision making. Can I share the screen, sir?
Yes, sir.
So my first is, do cylinders scare you? They should not. And I'll be sharing handling of astigmatic errors by refractive procedures. So we have come a long way in the journey of cataract surgery, starting with intracapsular cataract extraction, where I had my training as a PG student, and then shifting on to extracapsular cataract surgery, and then IOLs, introduction of the intraocular lens, and then moving on to phaco, then stitchless phaco, topicals, and then multifocals, and then the toric. And that has been the icing on the cake, and that is something which has really, really improved the results of surgery in many cases. So why do we need to think about astigmatism? It is known that more than 0.5 diopter corneal astigmatism is there in 73% of the general population, more than 1% in 32.7%. So it is a significant astigmatism. And if there is more than one diopter astigmatism, it needs to be taken care of, because if not handled or not corrected, the quality of the vision later on will not be good. So this is a huge chunk. That means every third person needs attention or focus or a solution towards astigmatism. 13% will have more than 1.5, and about 6 to 7% will have more than 2 diopters. And then we have cases coming with 5, 6, 7, 8 diopters also. So in order to obtain adequate refraction results at the time of cataract surgery, a distinct attention should be drawn to the ophthalmological biometric parameters, which are continuously changing even in adulthood, and to astigmatism of 1 or above, which is there in 32% of the population. If we are doing multifocals, we'll see that we may have to address astigmatism, which is 0.5 and above, which is 73% of the cases. Now, why the attention is towards or getting focused on to the astigmatism? Because we have raised patients' expectations to have a good unaided visual acuity, and we have trained the patients to expect perfect spectacle-free vision for distance. And the toric lenses are a great solution for astigmatism. And if we recollect our patients, we'll see that most of the cases who are not satisfied with quality of the vision are either cases with astigmatism, or then second important factor is the dry eyes. So in an uneventful surgery, the commonest cause for this is the post-operative astigmatism. Now, common reason for dissatisfaction, as I said, is poor vision due to glasses, and it is due to the post-operative astigmatism. Now, when we have a patient with astigmatism, we need to spend time on counseling, where we have to convince the patient the advantage of the toric oil for better uncorrected vision for distance. And we all know from our past experiences that those people who have a high slender, they are not always comfortable with glasses, because all these patients will have glasses for distance and near. They'll be either using bifocal or progressive glasses. And if they have a higher cylindrical number, they are not very comfortable, and they may feel the ground a little uneven, or things a little distorted, or edges of the table, they are not very good. So if you can control the astigmatism by adding the cylindrical number to the intraocular lens, the quality of the vision definitely increases and is much better. Although patient may still need glasses, and we need to explain also the need for rotating the lens if required. From the patient's perspective, the surgical procedure, the pre-operative preparation, post-operative experience remains the same as with the regular implants. All that changes are for the surgeon. So you educate the patient that the technology is available for astigmatic correction, give option of a toric implant to your patients having astigmatism, and you can achieve a fairly high level of spectacle freedom for distance when bilateral implants are done. A pre-operative workup in these cases definitely takes more time. The surgery definitely takes more time, and your OT staff has to be geared to handle these cases and assist you efficiently in additional steps which are required for toric implant. So therefore you will need a small change in your routine practice. I now would like to counsel the patient after the biometry has been done, because many times happens that patient is not wearing spectacles with a cylindrical number, and then you talk about the regular lens, and when you do biometry, patient comes back and you see it is 1.5 corneal astigmatism, and then you start talking about the toric lenses. So it is better that you talk about the implants or the toric or only after the patient had his biometry done. And patients having more than one cylinder are candidates for toric IOL. And if you're doing multifocal and it is less than one, then astigmatic keratotomy is required in these cases. The toric IOLs are one-piece lenses, and they have the markers for X's. Different companies will have different way of putting these dots. There may be dots, 3 dots, 4 dots, or some of the companies will put a line which will help you to align these lenses with the reference marking during the surgery. While selecting the patient, make sure patient has regular corneal astigmatism, make sure that the capsule is intact, and make sure that you'll be able to do a good capsulorhexis and in the bag placement. So the patients with pseudo-exfoliation, where you feel the support to the bag is not very good, now those are the cases where you may avoid using these implants. The important procedures, 3 important steps will be the intraocular lens calculations, then the marking on the eye, and the IOL alignment on the X's. The preoperative measurements are depending upon what system you are using. You will do keratometry, which can be on the keratometer or pentacam, or biometry, where you have an optical or ultrasound exit length. And now you have optical biometers like LensStar and ILMaster, which do everything. You just scan, it will give you the keratometry reading, the exit length, all the other parameters. And they have all formulae for different lenses. And you get, especially with the biometer, you get the TKR, which helps you to be more accurate in receiving astigmatic emetropia in the post-op period. So a good pre-operative workup is important, and we are doing the LensStar, ILMaster 700, and Pentacam in all cases. And it does become a challenge if the values are different on 3 different machines. And then you have to go back to the clinical examination, look at the cornea, and then make your best guess, where would you like to go in for. And then if the Pentacam readings are too off from the LensStar, then you need to use the central 2 or 2.5 millimeter readings from the Pentacam. So this I have already mentioned, and it's important that the corneal keratometric measurements are used in calculations and not the refractive astigmatism. Go for topography for unusual readings, or poor Myers if you are doing keratometry. Don't use refractive astigmatism, which I've already highlighted. We are going, whatever the lenticular astigmatism is there, since we are going to remove the lens, so that doesn't count for, or it need not be considered into it. And we all now realize that the optical biometry is ideal. It doesn't mean that you can't do toric implants if you don't have optical biometer. Only thing is that your results will be more accurate. And if you are doing multifocal torics, then definitely you need a very good tool to do an accurate biometry, because there your aim is to have a spherical as well as cylindrical correction and giving the patient the best possible emetropia and the best possible final visual results. I have seen there is a lot of times variation between the biometry done by the different residents or fellows or the different optometrists with you. And it is good idea to have one person fully trained into it and a second person who is equally good and as a backup to do the biometry, because how the patient is positioned, how the patient sits, how you open the eyes, how you make the patient blink, how you take care of the dryness, how if there are variations, you put lubricating drop, then do it again. So it is a little technical thing where you need a person who is eligible, who is trained to do the things in a repetitive way and who follows the protocol in doing, so that you get a consistent results. Another thing that we have been doing for now some years is that when the patient is first diagnosed with cataract, we do the biometry at that stage, and we do the biometry in both the eyes. Otherwise, many times I have seen when the patient comes, patient doesn't go in for surgery, want to get the surgery done later, and when the patient comes back, he has a white cataract. And I had problems in patients where one eye was multifocal and the patient comes with a white cataract in the other eye. Now that becomes a tick-lick situation. So now our protocol is that the moment patient is diagnosed with cataract, we do a biometry and keep with record with us. So that helps that helps you in handling a little difficult situations which do arise. Now this is the Barrett toric calculator which we use, and the software is very easy and intuitive. All you need to do is that you should have the printout of the biometry with you and all the parameters ready, where you add the surgeon, the patient's basic, you choose the lens which you're going to use. Then you have the flat K axis, and then you have the steep K and steep K axis, and then the exit length. And this is one step which I get it done in front of me on my OPD system by our cabin host. And I do cross-check that the readings that have been entered from the printout of the IL master, they are accurately fed into it so that there is no error due to wrong entry of the data, for which there remains a possibility. So a cross-checking, and I always get it done in front of me in my room. So this will give you, then you calculate, and then it will give you what lens or which lens will be doing, like in this case, 21.5 diopter ZCT 100, and it tells you that there will be residual 0.02 spherical equivalent. Most of the times you don't have to make any change into it. You go with it and you will get a good result. And the Barrett toric calculator is really good. So SIA is, again, most of us, we know that how much cornea we disturb when we make the incisions. So that much SIA you will add onto the calculator, and this is quite simple way to calculate it. And there is a SIA calculator. You feed your cases, 50 to 60 cases, and you will be able to get what your SIA is. Now we come to the second part. Once you have decided that how much is the astigmatism, you have done the pre-operative workup, you have counseled the patient, and you have decided which lens, that what axis you are going to place. Now comes the second part during surgery, which is divided into two parts. One is which is divided into the axis mark, first the reference marking, and then the axis marking. For this, make sure that the conjunctiva is not too wet and the patient's eye is stable, because it gives you just one chance to put the marks properly. And if the patient moves and you have marks which are not proper, then you put it second time, then there's a lot of confusion into that. So try to get your first mark perfect in each and every case. The preoperative marking is best done with the help of the slit lamp for stabilizing the head. And you can use the pen, or there are different tools which are available. You have pen and an eyeball system, and then you have a lot of commercial markers which are available. So the two steps are reference marking and axis marking. Reference marking is the pre-induction period, and preferably in the patient in the upright position. So you have two reference marks placed at the limbus, 180 degree apart. The marker that I am using, it puts 4 marks, 90 degree and 180 degrees, so that it gives you more. It does, when you put the marking, the axis marking, it is easier to center it. Now this is the instrument, and it has a heavy ball under it, so that whenever you hold it horizontally, the position of the axis of the markers or those points on the tip will always become at 180 or 90 degree. This is how it looks like. There are 4 markers, and you will put the ink onto these markers. And then this has those 4, if you see there are 2 rings, and between the 2 rings you can see the limbus, and that helps you to align it very nicely along the limbus. And then you just press it gently, and you get very good clear 4 marks, and they stay till the end of the surgery. Now, it is why alignment is that important. We all know that if it is 30 degree off, it's a total loss. That means for every 1 degree of rotation, 3.3% of the lens power is lost. And 30% of the rotation could cause complete loss of cylindrical power. So it is important that the toric implants are placed at the right axis, for which your pre-op calculations should be accurate, and your markings, reference markings, they should be accurate, and then your axis marking, they should be accurate. And as I said earlier, the OT staff has to be trained into it so that they make it easy for you and convenient for you to put all the marks, and all the instruments are quickly available to you. And it's a good idea to have a little smaller capsular axis, so around 5 mm, so that there is a good overlap, anterior capsular overlap over the intraocular lens optics to hold it in place. And don't base your capsulotomy on the size of the pupil. That is many times happens if the patient has a very widely dilated pupil. One may have a tendency to make a little bigger capsulotomy, especially if you are taking or tearing it along the pupillary border and you don't exactly focus onto the size, and it does happen at times. So the toric axis printout should be in front of you, and we put it, display it horizontally so that it is in the position when you are sitting on the temporal side. So I would like it to be put at right angle to the printout in a landscape mode, so that you are visually oriented to the axis that you are going to see. And also we write down how much degree rotation is required. This is how it is that we have a big screen where the EMR data is displayed. You can display it as it is seen here. Now what we do is we have incorporated into the EMR. This is the OT screen, and then it is built into it so that it is displayed there along with the patient's picture, so that you can identify the patient and the errors are not there. Now, this is the axis marking. So this is the instrument, and you will be putting the 4 notches and aligning them to the marks that you had put earlier. And this is the axis marking. Depending upon the degree on which you are, you will align these 2 wings along the axis and then put a mark on the cornea. So if you have 4 marks, it becomes quite easy to do it. And this is here, I'm putting the marks at 170 degree, and make sure the cornea is reasonably dry, or it is not too wet. Then you will get very discrete fine marks, which will help you to align the lens. So this case, I'm going ahead with the capsulotomy. I use a cystitome, and then making the main incision, doing hydrodissection, followed by hydrodelineation, then removing the epicortex, and then loading of the lens. And this is the insertion of the lens. And you remove the viscoelastic. And then I would inflate the eye completely and then see how much is the error left. And then if there is a very slight adjustment to be done, I'll do it with the tip of the cannula, and then make sure that the lens is finally aligned with it. It needs a little practice, but then it doesn't need much additional time to do it. So this is another case. Inserting the lens. Then during the IA, I would like to manipulate the lens with the tip of the IA and bring the axis close to the final position of the axis where you want it. After that, inflate the eye, wait for a minute or so, let the lens open up completely, then its chances of rotating are much less, and put it into the final position. And this is how the case is on day 1. And if you dilate, you will see that the axes are coming where you wanted it. So it is done as a gross alignment, which I'll do with the IA. And then you have the viscoelastic removal, and then you have the final alignment. Now, this is the case with the 4.5 diopter. Refraction was plus 1.5, and finally you have a 20 by 26 by 6 vision. Another case, and then another case again with a cylinder. So anything between 1 cylinder, 1.2 cylinder to 5, 6, 7, 8 cylinder, you will be able to correct it accurately. And the results in cases with high cylindrical number are very, very satisfying. It's important not to overcorrect it, always to undercorrect the cylinder. We don't want the axis to change. So the toric lenses have been one of the most significant advances that we have seen. It provides a safe and predictable alternative for cataract patients with coexisting astigmatism, and only minor modifications to a surgeon's routines cataracts techniques are required for the success. So this, I have already mentioned that the measurement should be accurate, and it's not difficult. A good optical biometry, standardized SIA, posterior segment evaluation, good keratometry, preferably pentacam, using a toric calculator, standardized toric calculator, a standardized and predictable surgical outcome, good capsular access, and a proficiency in handling the lens are important factors which will enhance the success and your results for the patient. If you are starting it now and you're not doing it earlier, then it will be a good idea to practice on non-toric IOLs just to understand and see how the lens behaves in your hand, how much force you need to rotate the lens, and you should get a feel of the behavior of the intraocular lens and its rotation before you move on to doing these toric implants. And it will be a good idea to have practice the markings also, and removing viscoelastic should practically be the same as you do it for the others. And it is safer and less stressful when you do your first toric implant. So the centration of the lens, the patient selection, pre-operative measurements, IL calculations are important. And if the eye is in high myopes, you can have a little issue that if it's a too big a capsule, the stability sometimes becomes an issue. Now, are there any other options available for marking this? Definitely yes. You have the Zeiss Callisto system and equivalent systems from other companies. And this is really good workflow in your outpatient department and surgery department. So when the patient gets registered at the reception and the surgery is advised, patient goes in for the biometry at the IL master. The data is saved onto the forum server automatically. And in the OT, when you switch on the Callisto, that data is automatically fetched. You have the reference image available there. You have the image captured at the table. And then these two are compared. And then it displays the marks onto the cornea. And in a virtual images, it will show you the site for the images. It will show you the site for LRI. It will show you for the capsulotomy. And what we need most for the toric implants, it will show you the markings of the Z-axis. So the complete Markerless suit will have, you need a Zeiss IL master, you need the OPMI Lumira microscope, and you need the Callisto eye. The best thing is that it makes the flow seamless. You don't have to spend extra time on marking or anything. And it is, I think, a little more accurate, but I am very comfortable with manual marking also. And those who want to start toric or do torics and don't have access to the Callisto or these should not be should not feel that they can't do without it. You can, with standardizing or doing good practice onto the manual marking, you can have excellent results. So this is how the Callisto works. And this is now we are taking the marking. This is what the marking has been taken. And this is the reference line. And these are the other incision marks which are displayed. And then you have this is the capsulotomy display comes. And then you have the Z-axis or the axis for the lens also displayed. So these are and it always shows as 3 lines, which helps you align completely. This is the Z calculator by Zeiss. And if you're using the Zeiss lenses, then I'll strongly recommend that you, especially if you're using the Zeiss trifocal lenses, I would strongly suggest that you do the calculations on Z-Calc, because we have found that the Zeiss lenses do much better if the calculations are done on the Zeiss calculator, because all their systems are kind of they all coordinated and they are all benchmarked for each other. So for all the Zeiss lenses, we'll be going to the Z calculator, and for the IL, for the Abbott lenses, we'll be going on to the Barrett calculator. So the data required is practically the same. You'll fill the basic data, and then you'll fill the data from the IL master, and it will give you the value. Now, this is the surgery being done at Callisto, and we have removed the nucleus fragments and then inserted the lens. Wait for some time, let the lens open up. As the lens is opening, you have enough time to bring it closer to the axis, because it is easy to rotate the lens when the loops have not opened. And this is, now you see, final position of the implant. So it becomes very convenient and accurate, and especially even in topical anesthesia, there is no issue. This is another case. Again, we have done flax. And we make the side port incisions. And then the main incision. And then removing the capsulotomy, and hydrodissection. We can see the wave going right up to the other end. Removing the epicortex. So we remove the fragments, do the polishing. And then insert the implant. These lenses are easy to handle, and I find that rotating them is easy, and they tend to stay during the surgery. These plate haptics lenses tend to stay at that point, and that's the end of the surgery. So, when you're doing cataract surgery, that is one situation where you will have the astigmatism, and whether you are doing monofocal lenses or you are doing multifocal lenses or trifocal lenses, you should be correcting the cylindrical number. Any astigmatism up to 0.8, 0.9, I'll be correcting. Between 0.5 to 0.8 or 9, I'll be correcting with the flax, doing the LRI. 1.91 or wherever the calculations show that you can use the ZCT 100, I'll be correcting the cylindrical number, and especially in the multifocal, it's very important. Now we have, as far as the correction is concerned, there I'll be touching on 2 points more. One is the phakic IOL, and the second is the refractive surgery on the cornea. Now, this is a calculation from, I use the Biotech lenses. This is their, again, online calculator. You feed all the information that is there. It is just a standard, just showing you the screen, how it looks like. And the standard thing you do, you add the data, and then it gives you a printout. It gives you the final position of the lens and how much axis you are going to rotate. So this is the printout of the case, and then this is how the case looks after the surgery. This is the pentacam figures, and let's quickly go through the steps of the surgery. Viscoelastic. The main incision. Folding of the lens is really easy, and that is one step which I really like in this lens, that it's very easy and quick to load. And it is a similar cartridge that you are used to using for the intraocular lenses. This step is important to make sure that the trailing loops don't get entangled into the piston. So you place it in the final, close to the final axis that you're doing. And you can see that the front loops, the front are already under the iris. And then you tuck the trailing, and you already have the reference axis coming, and then you do the final positioning. First is center the lens, and then I use the two instruments, and I find it convenient to rotate if it is required. And then make sure that the lens is properly centered. And removal of the viscoelastic. And this is on the day one. So this is another case. I'll not go through the video of these two cases now. So this is another case of Feki KIOL. And you can see it's nicely centered. So Callisto again is Callisto the final answer, or is it how much confidence you have? I would like to share this video with you. I did Callisto, I did first time, and I thought that the yellow line or the reference line is not coming as it should be. So I did it the second time, and this is how it was the second time, and this is doing it 3 times. So Callisto and can at times fool you. So you please make sure that the Callisto is appearing where it should be. Sometimes it can be grossly off, so you can't blindly follow the automated things also. So coming to the last part is that how do we handle astigmatism in SMILE? And these are the few cases that we had where the cylinder was more than the spherical. And with SMILE, it is possible to correct cylindrical number up to 5, and you can correct pure cylinder also up to 5 with very good results. So VisuMax accepts up to -10 diopters spherical, up to 5 diopters of cylinder, and minimum sphere is 0.5. But now they have improved. You can go to plus also. And I'll skip it. These are the standard selection. And you can do manual marking in these cases, or you can even, if you want to be more sure, you can take these cases, you can do the Callisto, take these cases to the VisuMax to get them to the microscope, mark their axis, then bring to the SMILE OT, and then you can do it. Otherwise, with the patient lying down and straight on the table on the machine, you can have a fairly accurate axis markings. So these are when you are marking the axis, you have these the horizontal vertical lines in the eyepiece, and based on this you will have the axis marking, and then rotation is done like this. If the patient eye rotates a little bit, because sometimes in some cases you have to rotate the face a little bit for proper docking. So then you just hold this and rotate it a little bit, and then you get your marking exactly in the horizontal, aligned to the horizontal line in your eyepiece. It's very easy. Even if you could rotate up to 30 degrees, there's no issue in suction. It remains very good. This is the actual video of a case. The yellow lines are just to highlight the position of those blue marks. And this is how the rotation. Now, in this case, we have rotated about 8 to 9 degrees only. This is a graphic representation of the whole thing. You dock, then you rotate the pack and align it properly, and then you fire the laser. That's as a standard procedure, and then you do the dissections of the lenticule, and the procedure finishes. And the correction of the cylindrical number in these cases is good. You have to be good at docking. That is the main thing. You should be able to have a properly good center docking the first time. That is important. So this is the cap lenticule and lenticule bed dissection, and then removing the lenticule with the forceps. And this is how it is actually. So that you see the axis is not exactly there. This is how you have rotated it, brought it exactly with the horizontal marker in your eyepiece, fire the laser, and then it is like standard removing the lenticule. And in using the Callisto, Artivo has really been very helpful in Callisto and seeing it clearly. Thank you so much.
Thank you, sir, for covering the astigmatic control and handling astigmatism in a complete holistic manner. Very nice presentation, a lot of learning from that. And a lot of appreciations have come by the viewers. Would like to have comments from the two panelists. Dr. Suresh?
Yes. Thank you very much, Dr. Grewal, sir, for your excellent presentation covering all details about the toric lenses. I have a very quick question from Dr. Grewal and all the panelists and Dr. Titial, sir, that you have mentioned about that the toric lenses should be used for regular astigmatism. I want to ask you about your experience of toric lenses in irregular astigmatism, such as keratoconus cases, or the cataract surgery with RK, previous RK cases, those with corneal scar or traumatic cataract cases. What is your experience of using the toric lenses in these difficult case scenario where the astigmatism is an irregular astigmatism?
Thank you. Thank you so much for your question. Now, if a patient has keratoconus, then we are going in for a phakic IOL or a ICL, and it is going to be toric. And the patient needs to be counseled that you will be much better than what you are. You may have a vision which will be a little better than what you have with glasses, but you may still need something because your vision may not come down to 6/6. So these cases, I would definitely like to go in for toric. If it is a scar case and it is a little to the side, it's an old injury, I know these cases are, the astigmatism has now stabilized. I would like to go in for a toric implant in these cases. Now, RK cases are a very challenging situation, and I would like to avoid doing a toric implant in these cases. For main reason is that these eyes don't have a stable cornea. Their cornea keeps on changing. So diurnal variation is there due to the pressure changes are there. So these cases I would like to avoid unless it's a very high cylindrical number. But then as a policy, I would not like to. If there is some special situation, I may go in for it. But in RK cases, I would avoid it.
Okay. And Dr. Agrawal, I would like to ask one more question. If you implant toric lens in hyperopic cases, for example, axial length of 21 diopter, 20 less than 21 diopter, versus myopic cases where axial length is more than 26 diopter. So, do you adjust, the lens power, the lens power, or you don't adjust anything? You follow the Barrett calculator?
I go with the Barrett.
Okay.
Dr. Piyush?
I would, sir, like to just point out the main consideration in toric calculation about the posterior astigmatism of the cornea. Like while treating with the rule astigmatism or against the rule astigmatism, do you take a difference in the calculation of undercorrecting or overcorrecting the cylinder in these cases?
At present, no, because we are using IL master and we are using the TKR, total keratometric refraction, and that is fairly good. That makes it more precise, that makes it more accurate and predictable, and that takes the guessing or adjustments out of it. So if you are using IL master, go with TKR, and you are doing toric.
Any message you will like to give to the audience, like who do not have an access to the TKR, or they would rather rely on the calculation given by the company guys or the routine Barrett suit which they have on their lens star? Then if they don't have an access to a posterior corneal astigmatism calculation, what essence do you feel that they should take care while treating against the rule or with the rule astigmatism in these cases, sir?
I think one can go with whatever the standard advice is at the moment, but posterior corneal curvature is unpredictable. It doesn't follow a set kind of a mathematical formulae in relation to the anterior surface. So there will always be a guessing component into it.
And treating astigmatisms up to about like what I have seen in Catalyst, like we are going up to about a 1.4, 1.5 with a fairly good predictable results. So any experience onto that, sir? That
yes, we have been doing, but now our cutoff is at 0.8, 0.9, especially with the trifocals. Because one difference between the LRI and the toric is that the toric, whatever correction you're doing with the toric implant is permanent. There's no regression in it. And we don't know how the cornea is going to behave, how the healing in that particular patient is going to be there, how the astigmatism will behave 2 years, 1 year down the line. There will always be some remodeling of the healing taking place. So my cutoff is, if the calculations suggest that you can put a toric, I'll put a toric.
No, that's what I wanted to ask you, that you have a vast experience of having been used these LRIs for the past so many years. Like, has your threshold gone down, seeing the regression over the years, or
yes,
why this change has been?
Yes,
like,
yes, yes.
Initially you were doing the higher ones.
LRI is very good for low powers. LRI is, if I have to compare, if I have a patient, let's say if I have a patient for 1 diopter, right, or 1.2 diopter, 1 or 1.2 diopter, and I have access to both LRI on Catalyst and to the trifocal, I'll go in for trifocal. Toric. I'll go in for the trifocal.
You will go in for a toric rather than going in for the LRI.
Yes. LRI we are keeping for cases between 0.5 to 0.9 or 1.
Okay. So your utility onto that is in a very limited span, I would say 0.5 to 0.9 only.
Absolutely.
Right. Any comments from the other panelists? I would like to share the experience.
Yeah, I guess the predictability of cylinder in the lens in the IOL is definitely more than the LRI. I would like to have comments from Yal sir. What does he feel on this issue?
I think, Rajesh, the point is well discussed. What Dr. Grewal sir was saying is absolutely correct. I think astigmatism part or threshold has really come down because of multifocal or a trifocal lenses come up. Little bit of cylinder can also make patient very unhappy in these scenarios. So it is better to correct them, even they have a 0.5 or between 0.5 to 0.9, which normally we don't take a serious consideration for a monofocal lenses. For trifocal lenses or a multifocal, it has to be taken into consideration. Other important thing is the use of LRIs or astigmatic keratotomies can be used in cases where you have a low cylinder, but sometimes the results can be very unpredictable. If you have an option of toric lenses, that should be the primary option for all these cases of any range of astigmatism. But yes, there are lenses which does not cover the high cylinder. Then we have a customized lenses can also be available from Indian manufacturers. So that is one good thing we have now. I think Piyush was asking about the posterior corneal curvature as does it make a difference to our patient or not? So I normally take these things into consideration when looking for a patient with a multifocal or trifocal toric lenses. Because we all know the posterior corneal curvature is normally against the rule, which does not change significantly with the age. Anterior can change. So if you presume that all cases are posterior against the rule astigmatism, if patient has an anterior curvature, which is again with the rule astigmatism. So you have a with the rule anterior and posterior against the rule. If you only consider anterior astigmatism by various devices, which doesn't give you a posterior corneal curvature, we are going to overcorrect this patient. So if you have a patient which has anterior against the rule and posterior against the rule, then you are going to undercorrect that patient. Right. So that has to be taken into consideration for a case where you are doing a multifocal or a trifocal toric lenses. But if you have a device which gives a TK, like an IL Master 700, you are safe. But if you don't have a device, then you have a various online formulas which can give you the estimation of posterior corneal curvature, and then iterate into your IL power calculation. So that should only be considered in cases where you're giving a multifocal or trifocal lens. If you're a routine toric lenses, it doesn't make a huge difference to your case, because the cylinder power is reasonably, it ranges around 0.3 or 0.37 against the rule posterior corneal curvature. That is one area. Other important thing is I normally, for a routine cataract patient, don't practice LRIs, but there are people who use LRIs because that's a simpler option for a cases where you don't have a toric lenses available. Now you have a lesser amount of toric lenses available also. That should be the option, because regression can occur, predictability may be issue. The white to white of patient may differ in different cases, and it all have a different ultimate outcome in these patients. Corneal curvature, white to white, that makes a huge difference in our outcome in these patients.
Thank you, sir. A lot of messages of appreciation have come, sir. A few questions as well. There's one question that if you use different toric calculators, the axis may be slightly different. Do you think that slight off axis does not make much of a difference in uncorrected visual acuity in spite of little bit of residual cylinder?
You see, as I said in my talk, that you need to see that which implant that you are using and which formula you're going to, which calculator you are going to use. And it'll be the best approach to use the calculator of the same company for which you are using the implant. So I follow that for, as I said, for the phakic IOL, we go to the Bartek's calculator. For Abbott, we go to the Barrett calculator, and for Zeiss, we go to the Zeiss calculator. I hope that answers the question.
Yes, sir. Yes, sir.
And if you have a residual astigmatism, sir, like what is your approach in a patient? Like if you see any personal experience on eye trace, like for a astigmatism in a already implanted toric patient, to actually re-rotate the lens, and what do you actually practice?
Okay, now the question of re-rotating the lens. Now you will re-rotate the lens if you find that the axis is not correct. And for that, what I do is I'll check the vision on day one. If the patient is not crisp 6/6, I'll dilate and confirm the axis. If the axis is not correct, then you need to rotate it. And then you go to the fixedastigmatism.com and you need the refraction. So if the patient is coming on day one post-op, vision is not 6/6, on examination, the eye is perfect as you expect on day one, and you are suspecting that the axis is not correct, then I'll suggest please get a good refraction done and get the best visual acuity possible, because it is the refraction on which you will be basing and how much rotation is to be done. Then you don't need any other calculations. It's what patient is accepting. So you may wait for 1 week and if there is a little corneal issue, or you feel there is a little edema around the incision and you feel that the corneal may change, then you may call the patient after 1 week, do a good refraction, and based on that, you do the rotation.
Any particular choice of timing you have, or you just wait for the corneal edema or the incision site to settle down and then you would just straight away go in for the rotation, sir?
Yes.
Okay. Generally, what I have seen is that if there is a slight amount of fibrosis which has started on the capsule, it becomes rather easy to place the lens, because the lens then does not rotate because there is a slight contraction in the capsule. So
Good.
Even if sir, your comment, please.
This is a great myth.
Okay.
Okay. Now it is very interesting to know when the lens rotates.
Mm-hmm.
Right? What my experience is and what I believe, the lens will rotate within 5 minutes of your finishing the surgery.
Very well.
If it stays there for 5 minutes, it's not going to rotate.
Right, sir.
I had 2 cases, and those 2 cases, I had to rotate the lenses. And the first thing I did was to go through the recordings. and the issue had occurred because of the removing the drape sheet was not done properly. So during that, there was a little pull on the lid and you could see things going wrong at that time. So reform the AC completely, wait for some minute, add 2 minutes extra time for your toric lenses, remove the drape very slowly so that there is no pressure on the lids, and inspect finally that it is okay. And if it is okay at that time, it is not going to rotate. Right now, the lens is in the bag. The lens is not touching any moving part within the eye. Lens, when it has opened, it doesn't have any internal force acting on it. The lens will rotate only if there is a if there is a circular force acting on the lens in relation to the capsular bag, which is not there. So lens will rotate within the first 5-7 minutes, and or it will rotate if the patient has rubbed the eye and the aqueous has gone out, AC has become flat. That is one situation where it may. Otherwise, lens, if you reform the AC very well, if you are sure your wound is not leaking, the lens will not rotate, because by basic physics laws, there is no force acting on the lens in relation to the capsular bag. It cannot rotate.
So there's a similar question actually related to that. And the question is that one of my patients had well-aligned IOL on day 1 and had 6/6 vision. But 2 weeks later, the patient came with slight blurring of vision and the IOL was found to be off axis by nearly 60 to 70 degrees. So I failed to understand the cause. What can be the cause for it?
One, there can be two possibilities. If the patient was high myope, as I said, that the capsular bag is bigger, then the lens is not stable. Second could be that the patient had some microtrauma and there was a leak in the AC. It can occur. I had a patient today only. That patient, I had done ICL 4 years back. And then when I examined the patient on the slit lamp, he had adherent glaucoma. He had the iris incarcerated or touching the incision with the ICL, right? So first thing I did was went back to the records, that why did it happen? I examined, I had the pictures of day 1 and day 14 with me, and it was perfectly all right. So the first thing I asked the patient, did you have an injury? The patient said, yes. I said, why didn't you come to us then? He said, I was in Canada. So I had an injury, and he had a picture of the eye also with a little iris prolapse, and that was many months after the. So these are the cases where we have seen that if the AC becomes shallow, the chances the lens may rotate. So that is why you form the AC fully and make sure that the AC is formed and is not going to leak. So in his case, probably there was some leak. Otherwise, the lens will not rotate, some injury or some leakage or myopic eye.
So there's one more question. Manual marking versus digital. There have been so many debates. What's your opinion?
Both are fine. Although I use 100% Callisto, but honest answer will be both are fine. Only thing is, in Callisto, I don't have to do anything at all. But if I'm doing manual marking, I have to have set protocol and make sure everything is okay, and then go ahead and follow it.
If I can add there, it is important that, as Dr. Grewal says, manual markings are equally effective in the toric lenses. Nothing to worry. I think people should go for a toric IOLs, not worrying that, if you don't have all these digital marking system, your IOL surgery will not be good. It's not true. You can achieve a very nice reference mark and axis mark with the manual techniques also. Only important thing is people have to get expertization in marking correctly. Most importantly, the initial reference marking has to be absolutely correct. Whichever method you like to use, you might use circular method, you might use pendular method, you might use routine, sitting position marking inferiorly, but that has to be done accurately. If that is true, your axis marking will always be correct because you have a higher magnification on the table. You can always do better. So initial reference marking has to be done more appropriately. And if you have a technician who's doing for you for many, many years, he'll always do a better job rather than some new person trying for you. That is what happens in our teaching institution. Every time some new person does, and you don't get a good reading. So I can just quote one of my publication, which got in JCRS, where we compared manual marking with a 3-point marker, that is a bubble marker, with Callisto. And as far as visual acuity were concerned, both had an equally good visual acuity in the post-op period. The difference was very minor. In the digital marking, the deviation was less than 4 degrees. And with manual marking, it was around 6 degrees. The only difference we could find was doing an eye trace in these patients, or the quality of vision, that is higher order ablation and the point spread function and MTF were a little better with the digital marking. Otherwise, acuity-wise, no difference. So that is what I can say here. People should not be worrying that they don't have a high-cost digital system. If you have, that's always better. Because as Dr. Garewal says, it saves your timing. You are much more comfortable during surgery also. So that is, and takes away the other hand doing something for you. And surgery results, people are doing now. Number of toric lenses for everybody has increased. It ranges from 10% to 30% or more sometimes of your OT list. So everybody has to learn this because that's a normal surgery for a patient nowadays.
And thank you, sir. I think that publication is really interesting. And if you notice in my today's talk, I spent more time on the manual marking than on the Callisto.
Yeah.
Dr. Grewal sir and Dr. Kitial sir, do you use toric lenses in pediatric age? Like, what is your cutoff limit for implanting toric lenses in children?
Sir, would you like to answer? Because
we do use quite often if the cylinder is little higher side, because it will be very difficult to get anything more than 1.5 cil in a pediatric patient, which is not going to change over in very soon. Though there will be some modifications in the corneal astigmatism as the person grows, but a high cylinder will never change. So that has to be corrected. Otherwise, the child will be totally dependent on glasses for a better visual acuity. And if it is a less than 6-year-old child, you still have an amblyopia developing in these patients. It may not be a good idea. But the cutoff age should also be appropriate. It's no point using a very high cylindrical IOL lenses for less than 1 or less than 2-year-old child, because the capsular bag fibrosis and requirement of secondary intervention is quite high in those cases. There, I might wait for a child we can put a primary non-toric lens, see how patient does, do a good refraction. If vision improves, we can always put a secondary lenses for these patients to correct. Now you have, I'm not done myself, but Psychoflex type of lenses are available in a toric variety also now. So other people also use a multifocal Psychoflex in these cases. But child, if it is more than 4 years of age and older, I normally, if the cylinder is more than 1.5, I do use a toric lens in these cases. There also, the major problem is the marking in these cases, because they are under general anesthesia, they can't fix. So your manual marking has to be absolutely correct. The reference marking has to be correct in these patients.
Thank you. So don't you think in these cases in children, the digital marking has a greater role to play? Because, the child may not cooperate for a manual marking. So
that is true, Rajesh. If you have digital, yes, why not use that? People now in our center who are doing more pediatric patients, like Dr. Sudarshan Kokar, he uses Aura also on the table to look into that aspect. People don't recommend in pediatric patients in GA, but he's going to come out with his results. And that's another category of, you can say, devices which can be used in a toric implantation for adults and pediatric patients. More for an adult patient, especially as Piyush was asking, like difficult cases, post-refractive surgery patients, where your calculation may be little not matching with the 2-3 devices. There we can add with the OptiWave refraction on the table, and that can give you some analysis. But major problem there is the inventory of lenses, because you need to have a 2-3 lenses with you so that you can actually take this the required lens for that patient, which is very difficult for most of us.
But as you were mentioning about Aura, about the Psychoflex lenses, what's your experience with the Psychoflex in correcting this toricity in the pediatric age group or even in the adult cases?
No,
With
as
the
Piyush, I
residual
said,
problem.
I have no experience myself because I've not used a toric Psychoflex yet. But
Okay.
that will be the option there now. And some of the Indian companies are coming with the the
With the
pseudophakic
Psychoflex
implants.
torics.
So that
True.
will give you more options. But whatever I have used toric lens in pediatric patients, they never are as predictable as the adult patients. That is what I've seen. Because maybe some axis deviation or the calculation may be a little difficult in a pediatric patient. Sometimes, as Rajesh talked about, capturing the images from the IOL master is also difficult in these cases. So even a digital system have a little difficulty in these cases. So
But
whichever
I
cases I've seen, they never get up to the required, the post-op refraction you want. But definitely, yes, it
they
does
help
decrease the
definitely.
cylindrical power.
Yes, with a very high pass, I have seen that the stability is quite good, and the residual correction has come out almost about an 80-90%. But what I am looking forward is the long-term results. How do the lens do? Whether there is any this lenticular membrane or something coming up in future or not. But so far, I had a follow-up of about 2 years, which probably the patient is doing quite well, I see.
Yes, normally now we all know pediatric surgery, the things have improved so much. The lenses are improved. Your concept has improved. The surgery we used to do in the 90s, we had so much of problem with the pediatric patient, which is we don't see now. And if you take a cutoff, as I said, if you have a more than 4 or 5 years old child, then we know that inflammation will be least possibility in these cases, unless it's sort of inflammatory cataract or something like that. So you have to be a little careful.
So there's one more question, and that is also very interesting. That can you comment on parallax? Many times I notice one mark is aligned and the other is not.
No, this is not uncommon. It does happen because it happens with the Callisto also. Make sure that when make sure that the patient is looking into the center of the light when it is capturing. If the eye is little not looking into the light, the Callisto will capture it, but you can have the mark not going through the optical center of the cornea. So you have to make a best guess in that situation, that where do those yellow line and those line joining the two marks on the lens, where is it meeting? So it is not uncommon. It does happen.
I think sometimes, I have seen, if you readjust your lenses, you might get correct orientation. Sometimes there may be little tilt happening in these cases, especially if the haptic and optics are not well oriented in the bag. So you might tap the lens little bit and move here and there. You might get correction. So that can be tried. We do have sometimes, especially when you have to put your lenses vertical orientation. There it's very difficult to have both the 3 dots aligned to the line which you have made. Horizontally is perfectly aligned most of the time. So vertically, I'm not sure that there may be some configuration change in the bag. So sometimes there are situations that Dr. Garewal sir is saying, you do have situation where both dots are not aligned to axis aligned to your lines. But if you have one aligned accurately, other one little bit 0 to 3 degree away, like you have, we saw that 3 lines are there in a Callisto. One is at middle line, other one is in the secondary lines. That's as good as aligned. So you should not manipulate too much. In that process, you might have more problems. But
So,
tilt has to be avoided in this case.
is it also because of the head tilt, sir? Because as you said that vertically,
If head tilt is there, then both the dots will be misaligned. If only the one is misaligned, one is correctly placed, that is tilt in the lens or in the bag orientation rather than the patient's tilt.
And there is another question, sir, regarding the rotation while what you do in the smile. When you're doing smile, you rotate the ring. So you had mentioned in your talk that there is no risk of suction loss, but then there's a question that, any risk of suction loss. So you have already mentioned that. How often you have encountered such a thing, sir? Any suction loss in any of the cases?
No, I have not encountered suction loss in that. And rotation also is not required that much, because in SMILE, if the position of the patient in the head position is okay, and usually you don't need to rotate. Usually it will be just 4 or 5 degrees or 5-6 degrees at the most. No issue of suction break.
Then there are a couple of repetitions, so we are going to ask the same thing. So any comment from any of the panelists? Detail, sir?
Yeah, I think it was a master class from the master himself and covered all the areas. I think people should understand this is not a different surgery. First, the important thing. There are many people, they have a mental barrier that is a different, higher grade surgery. It's not true. It's like a routine cataract surgery. And only thing is the lens has to be placed in a correct place. And we know that if you even have around 5-6 degree away from the main axis, hardly matters, because patient outcome is quite good in these cases also. As he rightly pointed out, not every patient will require a re-rotation. If you've done 100 cases, maybe one patient you might feel might be require rotation. Even there, if patient vision is 6/9 or the better, wait, and patient might say, okay, I don't want a secondary intervention, unless it is a multifocal or a trifocal lenses. And most of us are doing routine toric lenses in so many number. Not every patient we are looking for rotation. So if visual acuity is good, patient is comfortable, no need. But yes, there'll be a very few chance where you may have to take the patient. I'll recommend here, you take the patient to the routine operation theater, assess your patient, and then comfortably redial the lens. There are people in a Western country, they do OPD procedure also, which is in our situation is very risky. We should not follow that. Or people have done under slit lamp. They go with the 30 gauge needle and just tuck the lens, and that can only be done if you have a just 0 to 3 to 5 degree rotation. That to a little anti-clockwise lenses place. Clockwise you can rotate all these open loop haptic lenses. Plate haptic, yes, you might be able to. So that important thing has to be considered. As Piyush was asking, what is the right time? The patient is coming with the complaints, that's the right time to adjust that. The patient is comfortable, that's the right time for us. We will say, okay, don't worry, everything's all right. But there will be very rare cases where, as one of the case, you said more than 50, 60 degree rotation. That Dr. Grewal also nicely pointed out the reasons behind that. And those cases are difficult to re-rotate also, and they always go to same area again and again. So maybe we have to reassess and do look for a bag. We might put some other support system, maybe a CTR in those cases. Reassess, maybe the lens can be exchanged with the other design if the lens keep rotating. Because once the memory of lens is there in the bag, that should be taken care of.
Thank you, sir. Thanks a lot. And in the end, I would like to thank our master speaker, Dr. Grewal, sir. And it was a wonderful talk. And of course, our two panelists who are expert again in this field, Dr. Suresh Pandey and Dr. Piyush Kapoor, and President sir, Dr. Tyal sir. So thanks to all of you. And thanks to the support staff, our IT team led by Bageshwar, our staff Anil Kumar, and the sponsor IPCA for this webinar. So thank you very much. Thanks to all of you, and a very good night, and have a very nice and safe and happy weekend. Thank you.
Thank you so much.
Thank you very much.
Thank you.
Okay, Rajesh, I have to go to other session.
Okay, sir.
Other side.
Okay, sir. Bye, sir.
Bye-bye.
Okay, sir. Bye, Grevas.
Bye. Thank you.
Okay. Thank you so much, and my thanks to the ISCKRS for this opportunity.
Thank you, sir.
And thank
Thanks
you,
for
Suresh,
sparing.
and bye.
Bye, sir.